Now, the Purple for Maturity Summit is the first multi-sectorial forum by the AFPNC designed to include parents, patients, representatives, as well as key stakeholders in providing quality healthcare for babies born too soon, sick or small here in Ghana. This platform is created for key stakeholders to address critical issues on prematurity and share sustainable initiatives that can be implemented to improve and increase access to quality healthcare for babies born too soon, sick and small, as well as their families here in Ghana. And to welcome us this afternoon with a round of applause, shall we call on Dr. Isabella Sego-Moses. She is a child health specialist at the Accra College of Medicine. A round of applause for her.
Thank you very much, distinguished ladies and gentlemen. The CEO and founder of AFPNC, Selina Bentum, staff and students of Accra College of Medicine, the country director and representatives from WaterAid, our distinguished newborn champions, in particular Ohineyire Giftianti, recognizing all of you specially invited guests, good afternoon. Good afternoon. On behalf of Professor Efua Hesse, the president of Accra College of Medicine, I'm here to welcome all of us to this very important event. Accra College of Medicine is very excited to be collaborating with AFPNC, WaterAid, and other stakeholders to hold this very important forum. Preterms are special in that although they are born too soon and too small, they brave the odds to survive. And more I keep coming across very important people in society, and they whisper, I was a preemie, you know, which shows that more and more these very vulnerable little ones are surviving. But having said that, in the environment that we are in, their challenges are more than we can enumerate. They and their families fight against so much just to make it. And that is why it is a worthy cause for all of us to be part of this forum today and to be dedicated to advocating for access to quality health care for all preterm babies born in every corner of Ghana. As I was sitting there just a few minutes ago, some pictures were shared on a platform that I'm in, and it took me back to the 90s. The pictures came from St. Martin's Hospital in Agroyesu, and they are sharing on that platform what they are also doing to mark the World Prematurity Day. So efforts are being made all over the country and all over the world. And so we are very happy that this forum gives us the opportunity to chip in our bit. Thank you all for accepting our invitation to celebrate these special children and to be their voices, not only today, but in the days and years ahead of us. The Purple for Prematurity Summit promises to be very exciting, and I would like to urge all of us not just to listen, but when the opportunity comes up, to contribute to the discussions so that we will leave this forum knowing that we have some very concrete recommendations to move on. Once again, on behalf of Professor Efua Hesse of Accra College of Medicine and all our other collaborators, you are very, very welcome to this forum. Akwaba.
Thank you so much, Dr. Isabella Sego Moses. Another round of applause for her. Well, as a journalist, I had seen and heard some bits about prematurity and heard people's stories, but one person, one individual who made this very real to me is the person I will be introducing shortly. I know her as one person who is very passionate about her work. I've known her for a number of years now. We actually worked on a story together, and through her, I got a better understanding of preeclampsia. I'd heard it sounded very big, some scientific medical word. Wasn't too sure about what it was, but I mean, because we get into people's lives and we get to speak to them, I was impacted, not negatively, but greatly, to be an advocate when it comes to maternal and child health. So with a round of applause, I would want us to welcome the founder of African Foundation for Premature Babies and Neonatal Care, AFPNC, Selina Bentum. She's also the co-chair for this summit, representing parents and patients.
The African Foundation is the first Pan-African organization and network to represent the interests of preterm and newborn infants and their families in Africa. The foundation brings together disciplines and sciences with a common goal of improving long-term health of preterm and newborn children. So it's our mission to address the growing challenges of preterm birth and its effects on the children and their families through sustainable intervention initiatives in partnership with relevant stakeholders in Africa and beyond. So the African Foundation for Premature Babies and Neonatal Care started from my personal experience. I remember I just woke up one dawn and realized that my water had broken, and so I had to be rushed to the healthcare facility, and the doctor's first concern was to help my baby's lungs. And the doctor explained to me that I had suffered a condition called the premature rupture of the membrane. I was scared. For a first-time mother, didn't know what to expect, and the fact that I didn't have any medical condition that should suggest that I would have a preterm baby. He weighed just 1.4 kilos at 6 months, 5 days. We were separated at birth, taken to the neonatal intensive care unit here in Ghana, and that was a nightmare. I suffered lactation deficiency. He also suffered jaundice, and I lived each night during the days of our separation wondering if my baby was okay and had survived. I was gripped with fear, the fear of the unknown. When I saw other babies and what looked like the suffering, they were looking tiny and looked helpless. For a first-time mom, it made me wonder what other mothers were going through. That led me to extensive research into prematurity to understand why it happened to me. Who else is this happening to? And what are the policies by governments or institutions or non-governmental organizations doing to help improve the situation? By the time I finished with my research, I was inspired to start a foundation that will be opportunity to build stakeholder partnership so that we can work together to address the issues around babies born too soon, sick and small. So that was how the African Foundation for Premature Babies and Neonatal Care, AFPNC, was founded in 2015. The organization was founded to focus on 4 key areas. These 4 key areas became our priority as a result of the research we conducted. These include advocacy and awareness, research, improving quality and standards of care, and strengthening stakeholder partnership. We have committed to coming up with innovations or collaborating with key stakeholders in these 4 areas. In advocacy, we have made sure to campaign on issues surrounding clinical care, reproductive health, and also follow-up and continuing care. encouraging family-centered care initiatives across the neonatal intensive care units here in Ghana. We have partnered with organizations locally and internationally to create awareness on prematurity and other health-related issues regarding newborn and maternal health. We have worked closely with the Ghana Health Service, collaborating on specific projects, also collaborating with local organizations here in Ghana, partner with the European Foundation for the Care of Newborn Infants, and together through this collaboration we have implemented several projects in the past years and also reached out to hundreds of thousands of babies through our collaborative projects and our initiatives here at the AFPNC. One of our flagship projects and intervention has been the Purple Basket Project, where we provide essential items for mothers and babies in neonatal intensive care units here in Ghana, and also those who are in the follow-up care program in the facilities. The idea is to use this project to encourage attendance to antenatal care and also the follow-up care program. My baby did survive. Ken Luther. Ken survived. He's a 4th grader now and he's doing amazing, and he's an inspiration for what we do here. Just like other babies that we have met, champions who have survived in their families, they are all inspiration for what we do here at the African Foundation for Premature Babies and Neonatal Care. We are grateful for the support of our volunteers, institutions, groups, individuals who have believed in my vision and also believed in the vision of the organization to help us to achieve our set objectives. Continued support will help us to achieve our mission, to help babies born too soon, sick and small, and their families in Ghana and beyond to have the best possible start in healthcare.
Thank you very much. I think the video sums my statement of purpose. And I can't find the words because it seems like this moment is a dream come true. I didn't write a statement of purpose because it's right from my heart. When I was told that my baby came too soon, I didn't envisage being in a room like this with wonderful people like you. It's a bit emotional for me. I'm sorry. What we see when we step out and when we meet the right people who should make change, but sometimes it looks like they sit on the fence. I'm sorry. When I meet parents who have been struggling with fertility and they finally have a baby, but they lose their baby because the system just couldn't help. For those who have the money, they have the money, but they still can't make their baby alive. And for those who just can't afford care, but their babies have to pass on because they can't continue to pay for the medical bills. But there's a good part. I have met amazing people, healthcare professionals who wear their hearts on their sleeves, every day fighting to make our babies survive. Those who pay from their pocket to help our babies, and that is the good news. When we count the survivors,
is because a healthcare professional wakes up every day, regardless of the challenges they face in the healthcare facilities, and wake up every day to go help the babies to fight another day. And so I am grateful. But this moment is what we've been looking for because it is time. It is time not to leave the conversation on prematurity to only healthcare professionals, because they love their work, they love what they do, but they are limited in the extent of advocacy. In fact, they cannot fight the government who pays them. And so there's supposed to be a multi-sectoral approach on prematurity. The parents are equal partners like healthcare professionals, government, and the community. And so today, we have all gathered here as voices for babies born too soon in the NICUs right now. Our decisions, our discussions are going to influence them. And for those that might be born, our decisions here and what we will do after will determine whether they make it alive or not. So our purpose here today is to speak up, take action, and make it quick action so that babies born too soon here in Ghana can have the best possible start in healthcare. Thank you. And sorry, before I give the microphone, my purple dress was ruined. So for anyone who asked the question, why is she not wearing purple? I sewed a whole full purple outfit. Wanted to show up. But last night, we left here too late, and when I went, I couldn't fit into the dress. So I was given this to wear, and I hope that you will pardon me and give me nice compliments if you agree. Thank you.
Well, I was going to ask you, where is the purple dress? I was telling Ohinere, mine is when it comes to the family tree of the purple colors, it's down below, so it's called the peplet. So don't ask me why I'm wearing pink or a shade of pink. We are all in this together. Shall we give Selena a round of applause? Let's acknowledge her work. I mean, it takes a lot of effort to do what you're doing, and we so love you and appreciate you. Another round of applause for her. Next, we're going to hear from one of our main collaborators as well, and that is WaterAid. Let's welcome Akosia Kwafu Ojiri, the Programs Manager, Advocacy and Communications with WaterAid. Let's clap for her as she comes.
Hi, thank you very much, Wendy. I'm reading this on behalf of our country director. Like she said, my name is Akosia, but I'm the communications and media manager. So these are her words. Distinguished guests, champions of neonatal health here, media, the leadership of the Accra College of Medicine, ladies and gentlemen, good afternoon. It's an honor to stand with you here today at this Purple for Prematurity conference. This is a demonstration of our shared commitment to improving neonatal care and supporting the most vulnerable amongst us, premature babies and their families. We as WaterAid, we are proud to partner the African Foundation for Premature Babies and Neonatal Care in advancing this critical cause. At the heart of our partnership with the AFPNC lies a shared understanding that clean water, decent toilets, and good hygiene are not just enablers of healthcare, but they are fundamental rights and life-saving intervention, particularly in neonatal care. For premature babies, every moment is delicate, and every decision impacts survival. Yet, across many healthcare facilities, a silent but profound crisis persists. Insufficient water, sanitation, and hygiene services. This deficit undermines infection prevention and control measures. jeopardizing the safety of babies, mothers, and healthcare providers alike. We must draw an unbreakable link between WASH, which is water sanitation and hygiene, infection prevention and control, and quality neonatal care. Access to clean water, decent toilets, and good hygiene in healthcare facilities is a cornerstone of universal health coverage. It ensures safe delivery, quality service with profound benefits for women and girls, vulnerable groups, including premature infants. Water Aid Ghana, through our advocacy and programming, we will continue to champion WASH as a critical pillar of maternal and neonatal health. But as Selina said, we cannot do this alone. We need to all come together and we need to tackle the urgency that it demands. We need to integrate WASH into national and facility level maternal and newborn care policies. We need to increase investment in sustainable WASH infrastructure in healthcare facilities, particularly in the underserved areas. And we need to train healthcare workers on WASH and IPC to protect the lives of mothers and their babies. Together, we can create a world where every baby, regardless of how early they arrive, has a chance to survive and thrive in a safe and hygienic environment. Let us continue to recommit to building a future where clean water, decent toilets, and good hygiene are non-negotiables in healthcare for every mother and every baby. Thank you very much.
Thank you, Akosia. Next, we're also going to hear from the WHO, and we do have Dr. Sophanias Astrat. He's a coordinator for health systems and team lead for Universal Life course there as well. So he will be joining us shortly online. I told you that we're also streaming virtually on Facebook and then YouTube as well. So he will be joining us. Is the team ready? Do we have him online? Can you hear me, Doc? Hello, Doc. Mr. Soundman. Can you hear me, Doc? Well, today's event is also part of the commemoration of the World Prematurity Day, which we mark on November 17, and it does present an opportunity for stakeholders in maternal and newborn health to advocate, raise awareness, and support affected families to show solidarity. And it is in this light that AFPNC is collaborating with the Accra College of Medicine, Water Aid Ghana, and other key stakeholders to commemorate a 3-day activity, which includes today's summit, an awareness campaign, and also a NICU outreach. I'm told we have Dr. Astrat online now. Can you hear me, sir?
I can hear you very well, but I don't think you can hear me.
We can hear you. Can we hear him? Yes. We can hear you. You're very audible.
Very good.
Thank you.
Very good. Thank you very much. So good afternoon, co-chairs, distinguished participants, ladies and gentlemen, all protocols observed. I bring greetings from the officer in charge of the World Health Organization, Dr. Frank Lule, who would have loved to be with you had it not been for another equally important commitment. And apologies for not making it in person from my side as well due to other commitments. It is indeed a pleasure for WHO to join you in this stakeholder engagement to deliberate on very important issues in relation to premature babies in Ghana. Premature birth is a leading cause of neonatal mortality and long-term health complication, as you know, and it is higher in countries with lower socioeconomic development and in areas with more vulnerable families. Globally, 1 in 10 babies are born too early every year, and particularly approximately 1 million children die each year due to complications of preterm birth, and many of those who survive face lifetime disability. These numbers have not changed in the past decade, and prematurity remains the leading cause of death in children under the age of 5 years, with stark inequalities in survival rates around the world. In low-income settings, half of the babies born at or below 32 weeks die due to lack of feasible, cost-effective care, such as warmth and basic care for infections and breathing difficulties. The situation is not the same in high-income countries. And suboptimal use of technology and middle-income settings is causing an increase in burden of disability among preterm babies who survive the neonatal period. Premature birth, of course, remains a major challenge in Ghana, with many preterm infants lacking specialized care needed to survive and thrive. According to the most recent demographic and health survey, the neonatal mortality was 17 per 1,000 live births, while infant mortality was 28, and many of these diseases and disabilities are preventable with timely, appropriate care. Addressing this issue requires strategic, collaborative approach involving government, private sector, and the development partner. This year, coming to WHO as part of the World Prematurity Day, WHO held a global webinar which brought together a range of partners to galvanize action to reduce and manage preterm births. And last week, UNICEF, WHO, and UN Women organized Every Woman, Every Newborn, Everywhere Child Survival Action Summit in Dakar, where member countries, including Ghana, deliberated, among other priorities, on strategies to address the challenge in prevention and management of preterm births, as well as care for small and sick newborns. The action plan developed for the country will be rolled out in collaboration with the Ghana Health Service in 2025-26. As we strive to achieve a Sustainable Development Goal 3.2.2, aiming at ending preventable deaths of newborns and reduce neonatal mortality to at least 12 per 1,000 live births by 2030, it is imperative that we focus on increasing investments to improve access to quality health care for babies born too soon. While some progress have been made, we must continue to prioritize resource allocations to neonatal care. This includes investing in essential equipment such as incubators, ventilators, newborn resuscitation bags and masks, phototherapy equipment, radiant warm pulse oximeters, and other monitoring devices, as well as access to essential medicines, which are necessities for the care of preterm infants. Chairperson, over the past 9 years, Ghana's national newborn health strategy has achieved notable progress in strengthening essential newborn care. To build on these gains, we must expand nationwide access to basic care and prioritize care for at-risk small and sick newborns, particularly by enhancing level 2 care in district hospitals. It is crucial to equip health centers, hubs, especially in rural areas, with trained professionals and essential resources. Additionally, sustained investment with training and continuous professional development of healthcare professionals, doctors, nurses, and midwives will improve the quality of care in preterm infants, enhancing both survival rates and long-term health outcome. Everybody, regardless of birthplace, deserves quality of care. To support this, WHO is assisting the Ministry of Health and Ghana Health Service in renewing the quality of care strategy, and they're generating evidence using the harmonized health facility assessment quality of care module and patient-reported experience reporting survey. Governments should leverage on the expertise of resources of the private sector, which can contribute through healthcare investments and public campaigns, ensuring that preterm infants in Ghana receive the best possible start in life. In conclusion, investment in neonatal healthcare is a strategic necessity for the future of Ghana to improve the health and well-being of premature newborns. I'd like to state that WHO remains committed to continuing its collaboration with the Ministry of Health, Ghana Health Services, and all key stakeholders to improve access to quality health care for all, including every premature baby born in Ghana. On this note, I congratulate the African Foundation for Premature Babies and Neonatal Care and the Ghana College of Medicine on an excellent organization of this stakeholder summit to accelerate World Prematurity, to celebrate the World Prematurity Day. Thank you very much for your attention and for the opportunity. Thank you very much.
A round of applause for him. Thank you so much, Dr. Sophanias Astrat. He's the coordinator health systems with the WHO Ghana. We're grateful for your time, sir. And one of the key points he did indicates that some progress has been made, but we still have some more work to do. It's for this reason why we're also having this summit with key stakeholders to bring out some valid pointers that we need to improve maternal and child health care here in our country, Ghana. A round of applause for ourselves. I didn't hear that. I want it so loud that the security man at the entrance can hear you clap. So until I get that sound, you're not stopping. Thank you. We now move to our next speaker and our next solidarity message, and that's from UNICEF Ghana. We do have Manuel De West. I hope I got that right. Thank you. He is the Chief of Health with UNICEF Ghana. Let's welcome him.
Thank you very much. Ladies and gentlemen, good afternoon. I'm standing on existing protocols. I would like to thank you very much for this invitation. This is a very important event. You know, the mission of UNICEF is to support child well-being. We do that through different actions on different sectors, including health. And in the health sectors, we focus on different populations: mothers, newborns, children, and adolescents. Newborns are, in those four populations, probably the most vulnerable and those who need more help, particularly if they are born too small because of prematurity or because of other reasons. So being here with you today is very important. It means a lot for us. It means a lot for UNICEF. As mentioned just before, neonatal mortality has decreased in Ghana from 42 to 17 deaths per 1,000 live births. This is a very good achievement, but this decline has been slower than the decline of infant and child mortality. There are still around 70 newborns who die every day in Ghana because of prematurity, infections, and complications during delivery. And this is despite 80% of newborns being born in health facilities, which suggests that we may need to increase the quality of care in those facilities. There are a lot of interventions that can be implemented, as mentioned by our colleague from WHO. I think this is very good, and we have to converge and support the implementation of those interventions. But I think we need to go beyond that. We need to be innovative. We need innovative thinking to really achieve the best gain possible. One approach to improve quality of care may be the implementation of fully integrated healthcare for mothers and babies. Throughout the world, Obstetric and neonatal services have typically been organized in distinct departments with different guidelines, different providers, different locations for treatment. This model of care is healthcare worker-centered. It is designed to facilitate the work of doctors and nurses. For example, in many neonatal units, if you visit any neonatal unit in Ghana or in any other country, you will see that it's organized such as several newborns, sometimes up to 10 or even more, are grouped together in one room. This allows healthcare workers to directly observe all the patients and spend little time when moving from one patient to the other. In this model of care, mothers are hosted in a different ward or in a different area of the neonatal unit, and they can access the babies only a few times per day. This may be an important barrier to effective interventions, such as skin-to-skin contact, which is very important for very small babies, and reduce mortality by 25%, or also the promotion of early and continuous breastfeeding. The recent 2022 World Health Organization recommendations for care for premature babies recommend that mothers and babies should be kept together as much as possible to really allow the full implementation of many interventions which imply both mothers and babies. A fully integrated mother and baby model of care requires a lot of changes. It requires a lot of cultural changes, organizational changes, architectural changes, funding changes. So far, only few countries like Sweden and Finland have implemented fully integrated maternal and newborn care units with promising results. In Ghana, there is some initiatives to allow mothers to stay close to babies, either in a unit that's not too far or even in the same unit, but in another part of the unit. This is encouraging, but it's not sufficient. A fully integrated model of care will probably provide much important and sustainable gains. However, we need to build evidence that this can work, because, as I said, only few countries so far. We need to build evidence on the feasibility, costs, and benefits of such an approach in a country like Ghana. And Ghana could be a pioneer country to inspire other countries to follow that path. So, ladies and gentlemen, let's be innovative. I invite all of you who are interested in preterm care to join these kinds of initiatives and to move forward to develop fully integrated maternal and newborn services. This is going to help the progress to allow premature babies to survive and thrive. And let's use this kind of forum to move forward in those discussions and to move this agenda so it happens one day. Thank you very much for your attention.
Another one for him. And one of the things he also mentioned that caught my attention is the importance of cultural changes, organizational changes, funding changes, also working towards a fully integrated model of care here in Ghana. We still have some more work to do in terms of care for children and mothers as well. We do have a very special person coming up. I'm sure you're wondering who that person is. I'm the one. Well, we're all special here. Hello? She is a multiple award-winning CEO of the GDA Media and also a multiple award-winning journalist who doubles as a women's rights activist. Do you know who I'm talking about or who I'm referring to? Is she here? I think she's outside. We'll get her shortly. A well-respected, inspirational speaker in Africa and around the world. She is a proud product of Infantiman Girls Secondary School, holds a diploma. Okay, whoa. And we're wearing the colors as well. Yes, a round of applause for Infantiman Girls. She holds a diploma in journalism from the Ghana Institute of Journalism and a master's degree in international journalism from the City University, London. She is the CEO of GDA Media Limited and serves as an ambassador for the campaign against newborn deaths and the National Malaria Elimination Champion. Ohinire is the founder and president of the Gifty Auntie Foundation, which has a Girl in Need project and a Happy Day for Pregnant Women, Happy Feet, and the Awo Danswa Reading Project as part of its flagship projects. She is also an author. Her very latest book, I think, is outside, so you can go grab a copy. Make sure you grab a copy before you leave here. And the profile, I can keep going on and on. Should I keep going on and on? She's coming up already. Let's welcome Ohinire Gifty Auntie. A round of applause for her.
Thank you. I'm just wondering why my profile was read. Everybody was just simply introduced. Thank you very much, Wendy. I hope it's not because I'm your senior. All protocol observe, and indeed, purple is precious, not because that's the color of my school, but purple is precious. Purple is royalty. Purple is dignity. Purple is honor, and so are our preterm babies. 12 years ago, Dr. Sego Moses, I'm sure every time I tell the story, she's like, there she goes again, actually recruited me by force into becoming one of the ambassadors for the fight against newborn deaths. And I remember very well, we had a meeting at the Labadi Beach Hotel. And one of the things we strongly advocated for is that every child should be given a name before it is born. Because the fetus is a human being. And the mothers here will tell you that sometimes, I think from 6 weeks, you can actually feel the heartbeat of the child. And when we do this, we begin to take very good care of ourselves. And my focus is going to be on the family. Yes, we talked about healthcare, we talked about, government, donors, but I am going to focus my talk on the family owning this particular fight. Right from the day you were told that you were pregnant, we need to take our health seriously. We need to take antenatal seriously. We need to take our conversations with our doctors, our nurses, our midwives seriously. We need to treat that precious gift we carry with all the love, with all the compassion, with all the seriousness that they deserve. And we need to report every single anomaly that we experience in our body. One of my books, I think my 7th book, is the title is The Black Charlotte, Diary of the Late Bloomer and Her Daughter. And anyone who knows us knows that, yes, we've traveled a journey. Professor Ifua Hesi had sleepless nights. Dr. Sego Moses had sleepless night. Because every little thing I'm calling them and asking questions. Not everybody will have that privilege of having specialists to call even at midnight to talk to them. But we can go to the hospitals, we can go to the clinics, we can go to the midwives in our community to talk to them. The little thing, even when people tell you, oh, it's normal. I also went through that when I was pregnant. Please, make sure, cross-check. And apart from the stigma that we still attach to mothers who give birth to preterm babies by telling them that they are not strong enough, they couldn't hold themselves. I mean, some of the things you hear are very crazy, and sometimes you wonder if those who spew these words out are actually human beings and have brains in their minds. Some of the things they are told. Oh, you couldn't hold it. This, that. You're a woman. You are not a strong woman. I mean. And I remember the first time Selena came to my office. Yeah. You saw her cry today. My dress was wet that day. Set the pain. Sometimes our mothers also get confused and overwhelmed. And they just don't know what to do. Motherhood is torture. They say the joys of motherhood. Well, you make it a joy because you decide to, because it is tough. Having preterm or a special child, a child with disability or special needs, takes a lot of sacrifice, a lot of sleepless nights, a lot of mental fortitude. And they deserve all the support, all the care, all the love. But unfortunately, sometimes, not the men in this room, men run away and leave them. Families abandon them. And then all sorts of conditions set in. And they are totally lost. And then, through that, they lose their babies. A young woman, we prayed, as Selena was, narrating the story. She went through all the IVF like I did. For years, finally, she got pregnant, delivered. It was preterm, but it wasn't that bad. 2 weeks later, she runs back to the hospital. She's lost the baby. She said she breastfed the baby and put her to, did everything she's supposed to do. Put the baby to sleep. 2 hours later, she was going to check on the baby and she saw the breast milk just coming out of the nose and the mouth and everything. And everybody, the health professionals are saying what it is, right? Me, I don't know the name. Everybody was broken. It is not easy. It is not easy. So as families, as co-workers, as church members, as pastors, as community members, let's all rally and support and show love and compassion to pregnant women, to mothers who give birth too soon, to mothers with children with special needs. Because each of us matter. Together we form a community. Families can't do it all. Communities sometimes can't do it all. Societies, and it takes a whole nation, a continent, and now the global world. So let's show love, let's show compassion, let's show support, and chip in when we can. Thank you, and God bless you.
Thank you. Another round of applause for her. Like we've heard from her and Selena, it takes a lot of courage to share your story with the rest of the world. And I know that we also have some more stories to hear. We have a father here who would share his journey with us. Usually we'd hear from the mothers, but we have a father here as well. But some of the things she touched on, which we need to focus on, is the stigma associated with birthing preemies, which is a major challenge for these mothers and their families. And then they deserving all the support and the love we can give them. Are we ready, and do we pledge our support to families, mothers, and even to the preemies? Do we? Please show by hand and say, I do. One more time. Thank you. A round of applause for ourselves. Next, we have a musical interlude, and I'd like to invite Nana, the violinist. Nana. Okay, she's getting ready. She'll be here shortly. But if you have a tune, you can come up and sing for us. A round of applause for Nana as she comes up. So some love to Nana, the talented violinist. I should go learn how to do that. I'm inspired. We're going to have 2 panel discussions, but we'll start with the very first one, which focuses on science and clinical care. I'd love to call on Dr. Nana Okain Brako, a pediatrician and a fellow. He's a fellow in neonatology. Forgive me, I think I'm feeling hungry. Neonatology. A round of applause for him. He's with the Greater Accra Regional Newborn Focal Person. Doc, please move up here, please. Yes. You can be at the far left. Yes, thank you so much. And then the next person is Dr. Nabake Ama, a senior specialist obstetrics and gynecology at the Kolebu Teaching Hospital. Another round of applause for her. Doc, I need be in the middle. And then the next person is a father, Mr. Paul Fojo Jr., a parent and patient representative. He's also the head of operations and creative director, Placito Limited. Let's welcome him with a round of applause. Yes. Yeah. A round of applause for us. Thank you. Well, we've heard from guests, special guests. We've heard from leaders in the space when it comes to maternal health and childcare as well in our country. But we're going to delve into a very important discussion. We aim not to focus only on challenges, but also the incredible opportunities we have as stakeholders to make a lasting impact in improving healthcare for premature babies here in our country, Ghana. I will start with Dr. Ama. Now, we're looking at preconception and also the conception stage. From an OBGYN perspective, explain what premature. We have heard a lot about preemies and premature. We've seen pictures of babies in incubators with some wires in their noses and all that. But what really is prematurity and the factors that lead to preterm birth?
So, good afternoon. So, the textbook definition of prematurity is when a woman delivers a child before 37 weeks. So, up to 36 weeks, 6 days of gestational age. If you are born before then, you are premature. We have different levels of prematurity, depending on either the gestational age or the weight. So, below 28 weeks is severe prematurity. So, usually the weight tends to be less than 1 kilogram. Then we have those who are between 1 kilogram and 1.499 kilos. So that is not so preterm again. And then we have those between 1.5 and 2 kilos. And also we have those between 30 to 33 weeks, 33 to 36 weeks. So all those things are taken into consideration on the level of prematurity. But less than 28 weeks is severely premature. And in some circles is considered as actually pre-viable. It's not a viable baby. Yeah.
Thank you so much. Let's appreciate her. Now, when it comes to some of the best practices a woman can adopt to prevent a preterm birth, Dr. Brako, would you want to take that for me? I mean, we've heard stories of people being told that they are being irresponsible and why are they birthing babies at preemie stages, and there's so many myths surrounding these things. But indeed, can we prevent preterm birth?
Good afternoon. Thank you. I'm Dr. Brako. Preterm delivery cannot completely be prevented. As the obstetrician is here, she will be the best person to let you know that. But we have conditions that if you take time and you follow very well, you could either push the preterm to near term, or you could prepare the lungs of the baby, the brain of the baby, and deliver. Some of those conditions, we can talk about something like preeclampsia, or it means the mother develops BP. The obstetrician would have to control the BP and try to push the baby. But it gets to a point that nothing can be done. You either take the baby out or you lose the baby and the mother. And then a baby comes out as a preterm. Sometimes, due to some infections, the water can break. Okay, the commonest ones are the urinary tract infections that mothers do get, and into brackets, some vaginal discharges. All these things predisposes to possible early rupture of the membranes. Once the water breaks, then the baby, first it will start leaking. So the volume around the baby is normally in a swimming pool. That's how I'll call it. The liquor is in a pool, okay, and the baby is in. So if the water around the baby starts dropping, then the baby starts suffering inside. Also, it brings about some form of contractions, and baby has to come out. But then the obstetrician, again, will try to push the pregnancy by making sure antibiotics are given. A very good example I've been given is a swimming pool. You can get a swimming pool in a very filthy ground. But once you dig and you plant the swimming pool very well, the outside of the swimming pool has no contact with the inside. But when the water breaks, then the outside of the swimming pool, which might contain a lot of organisms, because in general, the genital tract and into brackets, the vagina of the mother normally has a lot of germs. Okay, some are good, some are bad. Those germs can now pass through the liquid and the baby can be infected inside. So that's when it ruptures, baby is bound to also come out. That's the second one that we can work a bit on. The third is something we call cervical incompetence. It's all about obs and gynae, though.
I was going to ask, would you want to add on when he's done?
Because, yeah.
Okay, so I think I didn't get to answer the second part of your question.
Okay.
So, preconception care in helping to reduce the incidence of preterm labor. So, diseases like hypertension, diabetes, sickle cell disease, anemia, obesity, uterine fibroids, genital tract infections, and HIV need to be identified, managed, and controlled before women get pregnant. We are beginning to see young women, 26, 28, with hypertension, with kidney disease, and it only gets worse when they get pregnant. And so if you have a medical condition, it needs to be identified before you get pregnant and managed, because pregnancy puts additional strain and stress on your body, and so it needs to be controlled. Especially with hypertension, if it's not controlled and the blood pressure goes very high, or worse, you get preeclampsia, we need to deliver you to save first your life. And usually preeclampsia starts around 20 weeks. When we give our medications, we monitor the mother, the baby, we're able to very often push, the aim is to get to 34 weeks, by which time we are assuming that the baby's weight will be about 2 kilos. A 2-kilogram baby can actually stay with the mother, doesn't have to be in the NICU. But the problem, and we are seeing this again and again, is that people have significant kidney problems from hypertension in pregnancy. If you go to the dialysis unit at Kolebu, I think women who have had preeclampsia form about 25% of the patients they're requiring acute dialysis. Some of them go on to develop chronic kidney disease. So we have young women who are 28, 29, 30, 35 on chronic dialysis. So it's important, everybody should take their own health seriously. It is your life, it is your health. The other thing that we see is we are having young women now coming with breast cancer and being pregnant at the same time. So we are forced to deliver the babies early in order for the breast cancer to be managed. So we work with the gynecologic oncologist. So you can actually start chemotherapy if you are pregnant. They have regimens for pregnant women. So usually we try to get the pregnancy to 34 weeks, deliver the baby, so that they can then do mastectomy and other things that need to be done to save the mother's life. We would like all healthcare workers to always discuss what are your fertility wishes with any woman who comes to any health facility, regardless of what she is there for. We should have this conversation with them, screen them for diabetes, hypertension, cervical cancer, breast cancer, sickle cell disease, anemia, advise people to lose weight. Women who are obese are more likely to get hypertension and diabetes when they get pregnant. So our general health is important. The other thing is that once we do get pregnant, it's important to go for antenatal care. So it's been consistently shown that women who don't attend antenatal care are more likely to have preterm labor. And they're also more likely to have low birth weight babies. Their babies are also more likely to need NICU admission. That's because they've simply not availed themselves of an opportunity to be screened and managed for certain diseases. So there's a lot of prematurity can actually not be prevented. So there's a lot of research going on. We hear, like you said, of infections. So vaginal candidiasis is very common in pregnancy. However, it's not actually a cause of premature rupture of membranes. So usually it is infection with bacteria like Staph aureus and E. coli. These live on our skin. And just like the lady from WaterAid was saying, personal hygiene is important in order to protect yourself from having unnecessary perineal and vaginal infections. The other thing that we try and do, this is becoming more common, is we try to measure the length of the cervix. That's the mouth of the womb. So you can use transvaginal ultrasound scan to measure the length of the mouth of the womb. So if it's 2.5 centimeters or less, it may be a sign that labor is imminent. So you can then put in a cerclage, what we call a thread. You're basically going to tie the mouth of the womb shut. The other thing that we use to try and prolong pregnancy is to give what we call progestogens. So in postgraduate circles, it's a bit controversial. Some countries use it, some countries don't. But here in Ghana, we use it. Okay. What progestogens do is essentially to keep the uterus quiet. The uterus is a muscle, and what progesterones do is to keep the uterus from contracting, to see if we can let the pregnancy progress further. Everybody takes malaria very lightly. However, the high fever for malaria can actually cause preterm contractions. It can let you go into labor. The same with urinary tract infections. If you have what we call frequency, so you find yourself urinating 5 times at night, it's not normal. Sometimes they will be told that, oh, because you are pregnant, the uterus is pressing on the bladder, but you should let a urine culture be done to see if there's any infection over there.
Okay.
Yeah.
Thank you. A round of applause for them. Now, we are hearing medical and clinical. We have some of these things, we've never even heard them before. But let's look at a real life situation. And I have a father. Usually I did mention early on that would hear some of these stories from the mothers. But I have a father who is an advocate. A round of applause for him. Paul, how can you give us a vivid example of all they've said through your journey of having a child? Is it a boy or a girl?
Boy.
Who was born preterm?
They've said so many things here. This, that. I can't even recall some of the terms they mentioned. Clinical, this, that. I mean, in plain terms, for people who aren't in the health space, how can you make us understand what this preemie journey is about?
Good afternoon.
Good afternoon.
When the doctors were speaking, one of the thoughts that came into my mind was, I wish I knew these things before my wife got pregnant. I was very ignorant as a prospective father. I did not, to be honest, I didn't even know about premature babies. I had no idea. And I agree with what she was saying, because also with the antenatal care, I was very surprised that nobody was asking for me as well. So all I knew is that I was going to be a father, but it was sort of like, that's women's business. You just, be on the side. I went along with it because I was like, this is how things are done. But looking at everything that transpired because everything that you were saying what actually happened. I was at home one day in the night and my wife said, hey, we have to go to the hospital. And I just gave myself the professional tag as chauffeur driver. That's all I had to do. I'll drive her, get to the hospital, wait. And she had to be admitted because she was leaking. I didn't worry, to be quite honest. I saw it as, these things sometimes happen. They were talking to her, but nobody was really talking, to me. So I'll get back to her and find out, okay, what is happening? And I was very positive-minded about the whole thing. I said, everything is going to be okay. To be quite honest, it was only after the whole ordeal that when I was reading, I was like, this was actually a very serious issue, but I was very strong because my son came in 27 weeks. All that time I thought, this is just something that happens. My wife was, emotionally, I could tell that things were going on. And I'm actually glad I was a bit ignorant because it helped me to be very positive for her as a pillar. But there was a lot of education that I wish I knew. I mean, what we're given by the time we took, yes, it was good. But I wish that once we knew we were going to be parents, there was a conversation about this could happen. And so prepare yourselves for that event if it does happen. We're not saying that we want it to happen, but just prepare yourselves, for it. As the father, kind of make sure that wifey is doing A, B, C, D. Support her in that area. We didn't get any of that. And for me also, once the baby was born, I think when the gentleman, I forget whether it's UNICEF, was speaking about the fact that the baby was... I saw my baby before my wife saw her. And I found that a bit weird because she should have first, at least that's how I envision things. But she just saw her for a few moments and it's like, you have to go. And I realized that messed with her mental state a lot. She wanted to be with the child, but for health reasons, and I understand what those reasons are, but it was difficult. Really, really, really difficult for her to spend only a few hours. Every time she comes back, you could see that she's longing to be, with the child. So, but nobody had prepared me or her for that ordeal. Nobody said, this is going to happen. You need to be strong for her. You need to do these things for her. So my general wish is that a lot more education, is provided not only by the healthcare, let's not put the whole burden, on them, but because everybody's on Google just checking to figure out what to do, but if more effort could be placed in central locations whereby we can go and access these things, I think it will help, it will go a long way.
Thank you so much, and a round of applause for him. I'm sure he's brought it home now. It sank in very well. Now, Dr. Bracco, we've heard Paul's story. I, for instance, as a journalist, I had the opportunity to visit some NICUs in hospitals, interact with health professionals. I had never seen a premiere. The first day I did, you can imagine my shock. And after I was told that, the baby will be fine, I saw pictures and videos of they growing up beautifully. He's reiterated the importance of education. How old is your baby now, Paul? Or your child now? Because I'm sure...
He's 8.
He's 8.
8 years old now, yeah.
So I would take you back to care and standards. 8 years ago, he said, and it's not like we're putting the blame entirely on health professionals. We all have a role to play. But would you say that standards have improved? We have a lot more education now, and we would have fathers who wouldn't have to go through what Paul, even though at a point he said he was thankful he didn't have that education. But now, it's relevant and it's very important. Has the story changed?
Yes, I'll say the story has really improved. Let's go as far back as 2006. That is no maternal insurance, health insurance. Okay. Before then, hospital delivery rate was very low. Okay. After the health insurance, we realized that the hospital delivery rate is getting better. Okay. So, around that time, I would say obstetric care also is not as it is today. Along the line, there was this introduction of what we call pre-pregnancy schools, okay, and pregnancy schools. It means before you get pregnant, you can now go in and access that service. I know many people don't know, and many institutions are not practicing it, but some institutions are doing so. Unfortunately, that one goes into the books of the couples who are not able to make children. Okay, but it is open to all. You can access it before you get pregnant. Now, when you get pregnant, there is also a pregnancy school in some of the institutions where you are educated as to how to go about things during the pregnancy and even after. Sometimes even labor is discussed. Okay, so we also have to make sure we patronize that. It was really doing very good before the COVID era, so it drops, but it started picking up, at least in the Greater Accra region. Okay. There are so many hospitals that are doing, I think the regional hospital is doing, and some of the district hospitals are also doing them. Yeah. I don't want to mention names, but there are so many doing them. Now, coming forward, neonatal care has also improved. I started the Ridge Hospital Neonatal Intensive Care Unit in a small area with the help of the CEO by then, Sroff, who decided that we use that place. Okay, small place, 3 incubators, 4 cots. When we started, we didn't know the burden was that high in the hospital because there was this concept of you come in, you deliver, you don't get your baby. So then we decided to open that. And within 2 weeks, all the beds were filled up. And then we asked ourselves, where were these babies going? Because by then I was in Kolebu and I moved to Ridge. And they were not coming to Kolebu. So where were they going to? You can ask yourself. So with the inception of that, I think many other small, what we call sick baby units, also into brackets, NICUs, has been instituted, where every district hospital, we expect that you get some small baby corner or a NICU so that you can see to those ones. Now, education has also increased because World Prematurity Day, Neonatal Jaundice Awareness Day, Birth Asphyxia Awareness Month, they are all there now. And we try to educate the public on all those complications. But you don't talk only about those complications. You talk about delivery and how it can lead to that, as we are doing for this prematurity. So I think a lot of education is going on. When it comes to equipment, also for neonatal care, there is an awareness that at least every district hospital should try and then acquire some equipment to help in the care of the babies. They are trying. When it comes to education, like manpower, also a lot of pediatricians are passing out now. We have the College of Nurses and Midwifery also running a lot of programs for newborn. We have the neonatal nurses, we have the pediatric nurses, we have other specialties, including nutrition and everything that would help in caring for this. But we are still not there because it's just a handful. Yeah.
We have heard Dr. Bracco say that we're still not there. And I did a juxtaposition with Paul's story 8 years ago. Is there something he hasn't touched on that you think you would want to touch on in terms of standards as well?
I think the Director General of the Ghana Health Service is not here, but I stand to be corrected. There are some aspects of the National Health Insurance Scheme that do not allow lower level facilities to stock certain drugs. So the children come, the mothers and their babies come from the community. So if you are at a health center, you are not allowed to give magnesium sulfate. Okay, you will not be, I stand to be corrected, yes. So the magnesium sulfate is not available at the health center, which is in the community, where the rupture of membranes happened before they move from there to the hospital. So we use the magnesium sulfate, number one, to prevent preterm labor after the membranes have ruptured. That's after the water has started leaking. We also use the magnesium sulfate to prevent seizures and cerebral palsy in the preterm infant. So can you imagine you are in a district, in a facility, in your home, in a rural area, and you have rupture of membranes? You get to the health facility, the midwife there is not under health insurance guidelines having the medications that you need. So they now have to transport you to the nearest district hospital. Some women are more than 2 hours away from the nearest district hospital. And just like he was saying, over here in Accra, I think we are very privileged. A lot of transport and so on. But some people, where they stay, to get to the road is 2 hours. When you get there, you have to wait for a car. Sogog is doing a project with Oxfam at KJG Health Center in the Sydney East District. They are on the other side of the Volta Lake. The road is very bad. So if you have preterm prom, that is your membranes have ruptured before 37 weeks, they need to put you first on a motorbike, or you take the Aboboya. From there, 2 hours to their nearest higher health facility. It goes faster if you take the ferry across the Volta Lake. But when you take, the ferry doesn't go after 6 p.m. Okay, so if you have rupture of membranes in the night, you have a choice to make. Either you wait till morning, or you go on the motorbike or the aboboya 2 hours through darkness. And sometimes they say they are attacked by armed robbers. And we were wondering, why would somebody attack a pregnant woman on a motorbike? Okay. Now when you get to the other side of the Volta Lake, you are still 1 hour away from the district hospital. So the ambulance you have to call the ambulance to come and pick you. And this can take 5, 6, 8, 10 hours. So there are a lot of problems at the community level with the health insurance, with our transport, that can interfere in the management of some of these conditions. The other thing is that as a society, and I think Madam Gifty-Enti alluded to it, we can be very cruel to women who have delivered preterm babies. So at Kolebu, we see assorted reactions. We see husbands like yourself who are very supportive, but some of the relatives shrink away. If you've given birth to a preterm baby, it's like you've not delivered. Okay, so some of the comments are, so is it this small baby that you couldn't push and you allowed them to do operation for you? That's one. The worst one that I've heard is, when others are delivering babies, look at what you have delivered. I think that sometimes we are wicked. Some of these things are wicked. Nobody even cares about how the woman feels. You know, about 2 years ago, there was a lady whose baby was at the NICU, 33 weeks pregnant, and she couldn't take it anymore. So she went to the 5th floor, decided to throw herself down. Okay. So, but from there are railings at the outer part of the building. So she fell from the 5th floor to the 4th floor and landed there. So patients and nurses on the 4th floor managed to keep her there, hold her there, while she refused to come inside. She refused to come back into the ward. So they called the fire service to climb up and bring her down. So people decided to go to NICU and just have a look. Maybe the baby's condition is very bad, that is why. But this was a 33-week baby that was playing with the wires in the incubator. You see, somebody will say that, oh, madam, but why? But you see, she has never seen what she's going through. She has never gone through what she's going through. We always portray people as having bouncing babies. If you look on television, every advert for baby clothes, you don't see preterm babies advertising diapers. People don't use preterm babies to advertise anything for any baby. So I think as a society, we should be kind and we should care. We should be patient and understanding.
Thank you so much, Doc. Paul, thank you so much. Doc spoke about perinatal depression, if I'm right, and she spoke about how mothers or family members react to the birth of a preterm child. You've also explained what your story was. As a father, did you leave the hospital empowered? Or what was it like for you? And then I would also want you to add a bit about stigma. Did you have to deal with that as well?
I would say I'm blessed that I don't think my wife dealt with any stigma or any of our family members or friends making her feel incompetent. So I'm grateful.
And that's the importance of
Yes.
education.
Yes, I'm grateful, for that. With the question of did I feel empowered or I was indifferent to some degree, blessed. I felt very blessed, but sort of indifferent, and I think it's just the way my outlook on life. I don't like considering myself special. The fact that I've been my first child is a preterm baby. It doesn't mean I'm less. It doesn't mean are more. I saw my role around that time as I began to understand my role as a husband and father a bit better, if anything at all. And I'll say this just because of what has been shared, because I recall we live, at the time, we lived around Sakumono, so this is around the Nungwa barrier. And the baby came in Kolibu, so we had to be moving to Kolibu. I think my wife even had to rent a little hostel space so that she could just make the time, because there's a specific time that she had to spend with the child on a daily basis until they released the child into our care. And so there was this one day that we went, and I'll wait in the car. She would go up to care for the baby. But when she did it, she came back relatively quickly, and I was a bit surprised. And she sat in the car, she started crying. And I was very confused. And I was like, what's going on? And in the midst of her tears, she explained to me that, similar to what you were talking about, that she was feeding the baby because she was still not, it wasn't breastfeeding, there was cup and spoon, yeah. So she was doing that, and the baby, she said milk started coming from his nostrils, and she got scared. And she got so scared that she left the child and just came back to the car. And at that moment, I knew that, okay, my wife is going through some very severe emotional issues, because that's not how, she is. So I was alarmed by what she told me, but I immediately realized that this is not the time for you to say, how can you? No. I just said, you know what, I get where you are coming from, but I need you to just go back and tell the nurses there that this is what happened. Her fear was that it would take longer. If she reports it, she may not, the time before she will be able to take the child home will be increased. And so that's what there's a lot of, and at that point I was just like, wow, Charlie, this thing, it affected her more than it affected, me. But I was just wondering, I was like, wow, I had no idea whatsoever. And it made me realize that I need to just be strong, for her. So I said, it's okay, you go. If there's a problem, you come and call me, I'll go with you. And when she went and she explained, she realized that everything was going to be okay. But I don't know what was talking to me in the back of my mind, that I need to not make her feel like she's going crazy. She later admitted that, yes, it seemed as if she was going into some sort of a depressive state. And the fact that I was able to just encourage her, say, everything is going to be okay. Because that's generally how I am. I'll be laughing at things and just trying to just keep the mood, positive. But I will say that I think there are lovely medical service people. This is nurses and doctors. But there are also some people who they test. And I say this because in the beginning, when she couldn't breastfeed, she felt less of a woman. And she will come back and complain to me that sometimes the nurses will be on a case, just go about it, as if she's already not trying or she already hasn't gone through an ordeal. Now, I know I'm not saying that all nurses are like that, but as the doctors were saying, there needs to be a lot of empathy when, as much as I as a husband or father can do to my spouse, generally there needs to be a lot of cushioning so that people can be okay, because I sort of felt like she was walking on eggshells. She didn't want to make a mistake. She wanted to be this perfect mother, and any sort of thing that can be seen as failure would further bring her, down. So anything that family staff at medical areas, churches, whatever you find can help in cushioning and just giving words of encouragement, it goes a long way in helping the journey of that child that is born.
Thank you, Paul. An applause for him. Now, Dr. Ama, I know that Dr. Bracco has said that in terms of standard, a lot has been done. But building on from Paul's experience, one, he told us that he didn't have enough sensitization when it comes to caring for a preterm, and even having a wife who was dealing with perinatal depression. The bit about family-centered programs in hospitals and even in our communities when it comes to mothers who are pregnant. Because I actually heard about perinatal depression through an advert that was running on TV by Basic Needs. And through that, I did a human interest story on 2 pregnant women. And that gave me a better understanding of it. That's how come today I'm able to talk about it. But family-centered programs, how are we going about it?
So I think the pediatricians are ahead of us on that one. They tend to have support groups. But increasingly, we've realized that sometimes the family is part of the problem, actually. So we prefer to speak to the mother and the father first, because we have what we call the house doctors, who have their own definition of prematurity, So the father and the mother are the primary caregivers of the child. So it's important that we say we need to take a social history. What is the family background? Are there people who can actually provide the right kind of support for this kind of lady? Sometimes we are dealing with a teenager, so we don't have any choice but to involve family members. So normally we start by counseling the mother and the father. And this is where I want to give a big shout out to all the nurses here for the pregnancy schools that they are organizing.
Clap, 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 clap.
Yes.
Oh, the nurses. So, if you're a nurse here, kindly show by hand. Hey, we don't have nurses here. Please stand up and let's give you some love. Let's show you some love. If you're a nurse here, up, 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 up. Let's show you some love. Thank you. Thank you so much for all you do. Thank you. Kindly have your seats.
So the nurses are key in taking the social history, getting to know the woman better as they interact with her. The nurses are the ones running the pregnancy schools. Pregnancy school, there's level 100, level 200, 300, 400. And then we have graduation ceremonies for pregnancy schools. It's all being organized by the nurses and the midwives. So it's important to talk to the clients, to involve the husbands. Unlike my friend here, many men are not interested in what happened. But because of the pregnancy schools, more men are coming to the hospital. They're also taking part in the pregnancy school. So at Polibu, for instance, the pregnancy school, a few men came. There was a day they were doing yoga. Can't you see the men also doing yoga on the floor next to their wives, stretching, showing them how to massage their wives, how to massage the back and things like that. So if slowly they will come. They will come. Some of them, our culture is like pregnancy is a woman's thing. So they don't know how. They don't know what to do. So as we educate them, so yes, education is key. Family-centered is important. But primarily is the mother, the one who has suffered the most, followed by the father. They are the primary caregivers. So we need to talk to them. And I think as healthcare workers, we need to be aware of the kind of language that we use. Pre-eclampsia with severe features, umbilical lateral Doppler, resistive index, pulsatility index. Those things mean nothing. Okay. So you need to break it down to simple language. Also, we forget that stress can make it difficult for a person to actually understand what you are saying. So the person is in front of you, and you believe you've had 10 minutes of significant conversation, but because the person is stressed, they haven't taken much. So healthcare workers need to be patient and then to repeat the message again and again in clear language. Sometimes you need to write it down. Sometimes you need to send them videos on WhatsApp explaining what the condition is so that they can take time to actually read through. So patience is key, and you need to be patient. Break it down into simple language. Repeat it again and again identify reliable family members. Not every family member is reliable or can be trusted. And then you move forward with discharging the premature child into the care of a family. In the same way, we need to educate our women that self-care is important. In the midst of going to NICU up and down, sometimes they don't bath, sometimes they don't eat. They are only thinking about their babies. So sometimes on the ward, the nurses identify them, sit them down. Have you bathed today? What is happening at NICU? Right now, you're not doing anything. Okay, you have a bath. I'll boil water for you. You go and bath. Have you eaten? So you need someone to specifically help them to focus on self-care. And then once you identify reliable family members, have a conversation with the family members. After discharge, this is what we want you to do. So sometimes we need to teach the mothers how to feed a preterm baby so that the mother can also sleep while a reliable person can help take care of the child. The fathers are also doing the kangaroo mother care. So they are also putting their babies on their chest with a cloth. They are doing it, so we thank them for that.
Thank you so much. Dr. Bracco, you were nodding, smiling when Dr. Ama was speaking. Would you want to add a thing or two before I ask the last question?
Yes. I was going to say that caring for the preterm without kangaroo mother care is something that becomes very challenging because of the lack of incubators and things in the system. And also not just the lack of incubators, but also making sure the mother can do what she's expected to do before she leaves the hospital. Because aspiration of breast milk is very common. And she needs to know how to manage all those things. Positioning, feeding, burping, changing of diapers, okay, and all those kind of things. Because there are techniques in doing all those things. Very, very important.
Okay,
yeah.
Thank you, Doc.
Let me add something. We cannot only talk about good things when it comes to the preterm. We expect everything to be as we are saying, but it's not like that. Because the journey of the preterm is something else, so challenging. So when stakeholders come in, we shouldn't only let them think it's just the immediate care of the newborn in the hospital, but we should let them know that the caregivers, the parents, should be part of that package. You are in the hospital, your child is at NICU, you don't have a place to stay. You sleep on the corridor. You don't even feel like eating. Some stay very far. And every 3 hours, we expect them to come and feed their babies. Really, it's a big thing. We need a hostel. We need a place that they can stay. Our KMC units are so small. So sometimes we have to even discharge babies through KMC, not having KMC. So they just do intermittent KMC on the ward, and then they are discharged. Okay, so all those things are stakeholder engagements that should take place.
No,
Okay,
my
thank
very
you.
last question to you is very much in line with the multi-sectorial approach. And what is your ideal? Briefly, what's your ideal? You've touched on involving parents. You've touched on the very basic amenities parents need when it comes to taking care of their preterm children as well. But ideally for you, if I had given you a blank check and I told you or I had given you a sheet of paper and I told you to tell me what exactly is your ideal situation when it comes to having a multi-sectorial approach for quality healthcare for all the relevant stakeholders, specifically the child or the babies and their parents, what would it be?
For a blank check, first of all, I'll talk about prevention. Okay. Although majority of the cases when it comes to preterms, cannot be prevented. The few that can be, if we are able to do it, it will bring a lot of satisfaction to the families. Okay. So that there is no, the person will not feel that guilt. Okay. I ruptured membranes and I didn't know. If we had made them to know, they will know what to do. So we should make sure the yes, like we should work on aspects of prevention. Now the second one is respiratory support for the ones that cannot make it. That's like a born preterm, because their primary problem is they would not be able to breathe. Okay. We have bigger machines that cost so much, but we have basic ones that can save life. So when we talk about insurance, we are not talking about bigger things. We are talking about little things that can help the system. So we should work on the basics. Okay, sometimes I hear insurance, people thinking about big things. No. Because majority of the people who might not make it will be due to very little things. The bigger ones, if they don't make it, it's sad. But then if you strike the average, you realize that for insurance, you need to cover a larger population.
Okay. Thank you so much. Dr. Ma, your bid will be on. I don't know if, because you're both doctors, sometimes the answers and questions, they get mixed up. But from your bit, for the healthcare professional's perspective.
I think that for healthcare professionals, we should take preconception care seriously. In fact, the population as a whole, your own health is very important. And I think there was a program on TV called Your Health is Your Concern. Yes, your health is your concern. You should be interested in what your blood pressure is. What is your fasting blood sugar? If you are obese, you are obese. Please accept it and do something about it. Don't say that I'm vertically challenged. We need to be honest with ourselves. That's the first thing. And healthcare workers should take every opportunity when they encounter a woman in the reproductive age group to screen, ask, are you trying to get pregnant? Let's do some basic checks. Diabetes, high blood pressure, are you a sickle cell disease patient? Do you have any vaginal infections? Do you have HIV? Those things we need to do. And then once they do get pregnant, attending antenatal early is important so that we can get the actual date. How many months pregnant are you? Occasionally, there's a difference between, for a premature baby, 31 weeks and 33 weeks can make a huge difference. So we need to know the accurate gestational age. So we would like women to start attending antenatal as soon as they miss their menses. You do the urine pregnancy test, is positive, please come. Though people will tell them that if you start antenatal, the evil eye will fall on you, they will see you. So wait until the stomach comes out before you go. We are pleading. The Holy Spirit covers us all. As soon as you see you are pregnant, please start the antenatal. If there's anything that can be identified early and managed, it will be done. During the antenatal period, everyone should take it seriously. Sometimes women are tired because of the long queues in our facility. So even when the nurses are giving educational talks, they are not listening. People are on their phone, looking at latest carbine slit styles, preparing for the outdooring. I don't have any problem with how you use your phone, but we should take antenatal care as a serious educational exercise. We ask the health workers to be very thorough in examining the patients, especially looking out for women who are at risk, those who have had a history of a preterm delivery, those who have hypertension, diabetes, and we are getting more women with chronic kidney disease and autoimmune diseases like SLE, rheumatoid arthritis. We need to look out for these patients. And then we should offer interventions. We have the soluble aspirin, which if it's given early can actually prevent or delay the onset of preeclampsia. And then we can give antenatal corticosteroids to help the babies breathe and also magnesium sulfate once the premature rupture of membranes or preterm labor starts. And we should be kind. Our attitude matters.
Thank you so much. Paul, from a parent's perspective, what does your ideal, how do you envisage quality healthcare?
A lot of what they've said speaks to quality healthcare. I would say that parents should also be optimistic and allow the healthcare givers or put trust in them. Sometimes there's this unfortunate perception that because we are in Ghana, things are not going to go well. And I think it does everybody a disservice. It does the whole system a disservice. You, the person even going there, you already don't trust or hope that these people are going to put their best. We need to start giving people the benefit of not everybody is bad. There may be, let's not allow the few bad ones to mess up the whole picture. There are people trying to create a better picture for Ghana and for the community, at large. And I think sometimes because parents are in that position whereby I'm going to have a child and we are the sort of the customer, sometimes we give the healthcare practitioners a tough time. But if we can work together and be optimistic, I think it will change the narrative, going forward. Let's advocate where we need to do so. Let's call out wrongdoings when it's done. But more importantly, we should learn to work with all the stakeholders, not just for ourselves, but for those who are going to come in the future.
Well, thank you so much. A big round of applause for my panelists. Dr. Nana Okai-Bracco, he's a pediatrician. Mr. Paul Fojo Jr., a parent and patient representative. He's also the head of operations and creative director of Placito Limited. And Dr. Na Bake Ama, a senior specialist obstetrics and gynecologist, Korle Bu Teaching Hospital. A round of applause for them. We're going to take a 15-minute break. We have some yummies, some savories across that room, so please stretch your legs. Don't run away home because we haven't closed. We have something special for you, so don't leave. We'll have our second panel discussion after the break, so see you soon. Thank you so much.
The African Foundation is the first Pan-African organization and network to represent the interests of preterm and newborn infants and their families in Africa. The foundation brings together disciplines and sciences with a common goal of improving long-term health of preterm and newborn children. So it's our mission to address the growing challenges of preterm birth and its effects on the children and their families through sustainable intervention initiatives in partnership with relevant stakeholders in Africa and beyond. So the African Foundation for Premature Babies and Neonatal Care.
We have just a 15 minutes break. Please don't leave. We'll come back and then wrap up. Professor Hesse is also on her way here.
And so I had to be rushed to the healthcare facility. And the doctor's first concern was to help my baby's lungs. And the doctor explained to me that I had suffered a condition called the premature rupture of the membrane. I was scared for a first-time mother.
Also, you can use this opportunity to network, get to know people. Some persons here you've never met before. Say hello to them, grab some savories, and please come back in. Thank you. Oh. Dear all, can we please get seated? Take your seat, sir. Can we please take our seats now? You can take it inside. Take our seats. Take our seats.
Thank you so much, Nana. A big round of applause for her. Those outside, can we have you in, please? Can I get one of the ushers to go out there and kindly remind them that we're starting the next session? Someone celebrating a birthday here? But we're not celebrating a birthday. Today we're celebrating someone who is very special and dear to the health fraternity. She's a mother. She's dear to a number of people as well. Very dear to Selina as well. And we will be recognizing her this afternoon. I won't mention her name. Selina will do that. But I also want to reintroduce Selina to you as well. Selina Bentum is an international development consultant, a human resource professional, an advocate for maternal and newborn health, and the founder and executive director of the African Foundation for Premature Babies and Neonatal Care, AFPNC. Selina is the first African to become a two-term elected member of the Parents Advisory Board of the European Foundation for the Care of Newborn Infants and the Global Alliance for Newborn Care. Is Selina here? Let's welcome Selina with a round of applause. Let's keep clapping.
We just got joined by a special guest. We had to do this together. So this is King Luther, my son. Yesterday he said to me that, Mommy, this is the first one. Can I just take some few hours off class and just come? Man, do you really have to say, yeah, I think it's a big deal. Don't you think? I say, yeah, it's a big deal. So this is the first one. Well, this segment we think is the highlight of this. This is a time where we call it the honorary personality feature. So every year, this is the first one we're doing, so every year we will be honoring an individual, whether a parent or a personality actually, who has distinguished herself or himself and made a significant contribution towards maternal and newborn care. This person isn't just someone who is just a healthcare professional, but she has a heart for people in a special way. One of the key challenges that I had when I started work was my ability to engage healthcare professionals. It wasn't easy. Although there are others that have been warm, I think that her support for parent-patient community through the foundation has been exceptional. We have not seen this ever. If not for her support, we couldn't have made it. We couldn't have achieved this. So we want you to have a quick look on your screen. I've just given a brief, but the screen is going to tell you how special this person is, not just to us, but for many of you here.
Professor Mrs. Efua Ejo Jekti Hesse, born on September 11, 1953, in Kumasi, Ghana, is a highly accomplished surgeon, academician, and administrator with over 45 years of professional experience. Professor Hesse is a pioneer in Ghana's medical field, becoming the first female head of the Department of Surgery at the University of Ghana Medical School, UGMS, and the first female director of medical affairs at Kolebu Teaching Hospital.
I've known Professor Efua Hesse since my medical school days. I went to medical school at the Premier University of Ghana Medical School. And at the time, she was the head of department for surgery. She subsequently became the acting chief executive director of the Kolebu Teaching Hospital.
She is a wonderful person whom I've known for many years. When I was in medical school, when I did my internship in pediatric surgery and in my training to be a pediatric surgeon and thereafter.
She has held numerous influential positions, including acting CEO of Kolebu Teaching Hospital and chairperson of the Faculty of Surgery at the Ghana College of Physicians and Surgeons. She co-founded the Accra College of Medicine in 2015 and has served as its president and CEO. Professor Hesse has received numerous accolades, including Millennium Excellence Award for Medical Leadership 2010, Lifetime Achievement Award from the Medical Women's Association of Ghana 2016, Glitz Woman of the Year in Health 2019, African Women Leadership Network Gender Champion Award 2024. Her leadership and dedication have left an indelible mark on medical education and healthcare delivery in Ghana. She has trained over 45 pediatric surgeons and more than 210 general surgical specialists across Africa. Additionally, she has supervised dissertations for over 40 pediatric surgeons and published extensively in peer-reviewed journals.
She has indeed contributed significantly and immensely to the health of children in Ghana and in West Africa. She is an educator, having taught medical students, trainee surgeons, surgeons who have even finished their training, and she continues to mold surgeons to be better surgeons to serve our nation.
An advocate for gender equity and maternal child health, Professor Hesse has championed initiatives like training traditional circumcisers in safe practices and establishing the first well woman clinic in Ghana. Her outreach efforts have significantly impacted underserved regions in Ghana through free pediatric surgical services and mentorship for local doctors.
So when I decided to start the NGO, I have an NGO called Hope for Little Lives where we do free surgeries for children in deprived communities. I thought it wise to let her know because she's a pioneer in the field. And she really welcomed the idea. She encouraged me. She supported me. We've been in existence since October 2021. And for our first outreach, this 60-plus old woman went with us all the way to the Upper West region of Ghana, to be precise. And this gave us so much credibility that to have the first female pediatric surgeon, Prof. Hesse, with you, it meant that you were doing the right thing. Prof, you don't know how much that means to me.
She is a real trailblazer, having rendered outreaches to various parts of Ghana, including Tetekwashi Memorial Hospital, Whole Teaching Hospital, when it was Whole Regional Hospital. She used to go there to offer regular surgical services for children who couldn't come to Accra to obtain such care.
Her influence extends to national health policies, including her contributions to the Ghana Health Insurance Scheme and the National Accreditation Board. Professor Mrs. Efua Ejo Jekti Hesse embodies excellence, leadership, and compassion. Her lifelong commitment to education, healthcare innovation, and community service continues to inspire many within Ghana and beyond.
Wonderful. We are doing the co-MCing together. So without wasting my time, we would have to call Ohinere Gifty Auntie. She has her personal experience as well when it comes to engaging Prof, and she will do us the honors by presenting the citation together with King Luther that Prof, one of your babies, the people that you trained, God used them to save my baby, and we are honored. This is the reason why King is here, to give you your flowers.
What can I say? You know, I'm even teary because I don't want to look at her face. Prof Sometimes those who have not had that encounter with her may think we exaggerate. But this is a woman who doesn't have to know you to help you. If one day we are to bring together all the children that Prof has helped in one way or the other, and the mothers, I tell you, we will fill the stadium and over. And she does it without, what's the word? The word that you people use. Without any hassle. She does it because she loves to do it. And she never gives up. I look up to her, and I hope the student here will look up to her. Look at how she's looking. Still beautiful, still healthy, still amazing, still full of smiles. All because she's a woman filled with love and sacrifice. And when the Bible says that when we give, we receive, this is a clear example. And he or she who gives is really the richest amongst us. Prof, we salute you. We salute you. We humbly call you to join us here. Ken, join me here. Now let me read the citation in honor of Prof. Ken, help me. It says, you have nurtured dreams of many in healthcare and demonstrated exceptional leadership and commitment throughout your career. As a pioneer in the medical field, you have set standards of excellence in healthcare, education, and service. Your hard work, integrity, and ability to overcome challenges have made you a source of inspiration to many. Through your mentorship and groundbreaking contributions to pediatrics, surgery, and maternal health, you have touched countless lives and shaped the future of healthcare. Your legacy continues to inspire the future generation of healthcare professionals and leaders. Thank you for giving parents and patients a voice through your selfless support for the African Foundation for Premature Babies and Neonatal Care. Congratulations on your remarkable achievements so far, and we urge you to continue to fight on. You are officially a champion. Can we all be upstanding? Three loud cheers for the Prof. Hip, hip, hip. Hip, hip, hip. Hip, 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 hip. Now, you take a book. No, where's Nana? Nana, please play. For she's a jolly good fella. Yeah, that one. Who has a good voice? For she's a jolly good woman. Please, once again, let's all be upstanding and applaud the woman of the moment.
Another round of applause for Prof. She said she wasn't expecting this. We love you so much and we appreciate you and thank you for all you do and keep inspiring generations as well. We pray for long life for you to be able to impact more lives as well. Thank you so much. A round of applause. We'll be wrapping up soon, but we have a final panel discussion. Oh, Ben, very short. Okay, so I'd want to invite my panelists up here. First, let's welcome Mrs. Perpetua Ampofo. A round of applause for her. She's the President's Ghana Registered Nurses and Midwifery Association. Oh, for Ampofo, we are sorry. Thank you so much. And next, please sit on my extreme left. Thank you. Next, we have Irene Owusu Poku, Health Policy Analyst, Water Aid. And the very final person is our very own Ohinire Gifty Auntie. All women, yes. Initially, the first one, we had 2 gentlemen and 1 female. Yes, minus Wendy. A round of applause for her. She's also our special guest of honor for this afternoon. Thank you so much. Let's keep clapping. Well, like I did mention early on, we did hear some leading voices in our very first panel on some clinical care. We took a parent's perspective. But now we're also going to look at, from my esteemed panelists this afternoon, who are all women, will be sharing their expertise and then also their thoughts on policy initiatives and what we need to do as a country to improve lives. Not just lives, but that of children, babies and their mothers, including their fathers as well. A round of applause. I would first go to Ohinire. You, aside from being a media personality, you're also an advocate and you've championed a lot of causes, including that of babies. Who should lead policy formulation and implementation? And how can we achieve a multi-sectorial approach when it comes to all these things we've spoken about today?
Who should lead? Hello? Yes. I think it must be, the approach must be multifaceted, which must include health professionals, parents, and advocates to amplify the voices, come together to make one loud voice to push. Because if we are not well coordinated, if we are not on the same page, we'll be singing different songs. And we've seen this happen most of the time. And it makes policy makers, lawmakers, government take advantage of it and say, look at them, they don't have their act together. Where do we go to? Who do we listen to? And therefore nothing is done. So we need to come together and form a formidable force or voice to champion the cause.
Thank you so much. A round of applause for her. Can you hear me? A round of applause for her, please. She says we need a multifaceted approach. Mrs. Ofori Otu. Ampofo. Hey, forgive me. Oh. I know this woman. Oh. I've known her for years. So forgive me. Pardon me. Probably it's just the excitement of seeing you again. That's okay. Thank you. Now, Ohinire is saying we need a multifaceted approach. Now, in this multifaceted approach, you are a key stakeholder. Mm-hmm. I remember when I was very young, I heard about brain drain. And I was asking, what is this? Is there brain draining? What exactly is the problem? And we know that one of the very big challenges as well from the health sector is health staffing. There are issues on that. How do you think we can improve that to better ensure that we save the lives of these babies?
Okay. Good afternoon, everyone. This approach. So you see, when it comes to, just like Ohnere said, it's a multifaceted approach. But when you look at what we do as countries, member nations under the World Health Organization, under the United Nations, all these international bodies, the World Health Organization sets standards for health in all aspects. When it comes to prematurity care, there are standards that have been set. It's up to all nations to embrace this and implement same. So when you look at the Sustainable Development Goal 3, there is something about reducing deaths of premature babies or neonates in general. And it's important that we look at it and address the issues as stakeholders. So for us as nurses and midwives, we provide care, we provide health services. Amongst us are specialists who are involved in the care of these premature babies. So we have pediatric nurses, we have critical care nurses, we have neonatal specialists who graduate from the college and all of that. So they are the bedside providing care for these babies. And of course, you have in some settings midwives and some nurses as well. When you look at the global standards for nurse to patient ratio, and the patient here being the premature baby, it should be 1:2, topmost 1:3. But in our settings, it's usually 1:8, which will not augur well for the care of the baby. And it's important that we look at the training. We need to train more of these specialists to be at the bedside to provide the care that is needed. More importantly, to look at the infrastructure. If you listened well to the first panel, NICU are created in health facilities where the space is just created for them. It is not constructed as part of the facility. So we need to move away from these ad hoc creation of NICU to more established centers that have what it takes to run a proper NICU. So in most settings, you find that the incubators or the cots are just 1 meter apart. Ideally, it should be 4 meters apart for each of these cots, and to ensure that we get the best care that we need for our babies. So when you talk about human resource, when you talk about specialist nurses or maybe our doctors who need to be there, we don't have enough of them. And you mentioned immigration. Now, those who are moving out are the best of our nurses, and they are the specialists I talked about. They are the ones leaving, and we need to find strategies to help retain them in country. I don't want to dwell on those things because today we are talking about our special patients, which are the babies, so the premature babies. So I don't want to go in that angle. But the truth of the matter is we need to do more as a country by ensuring that remuneration is better, conditions of service are better, then we attract them to stay. But we need to train more of these specialists to be able to provide the care that is required. Because, truth be told, aside the infrastructure and the lack of the specialists being there, we also lack the equipment. You talk about incubators, you talk about Firefly, the CPAP machines and all of those things. We don't have enough of all those things. We are just hanging there and doing the best we can within the circumstance. When I was training as a nurse, the mantra was improvise, improvise, improvise. Today, we are still improvising. We are still improvising. And you wonder, after so many years, what is it that we are not getting right as a country? And it comes back to the issue of investment in health. We are not doing too well. A lot of countries within the sub-region signed on to the Abuja Declaration as far back as somewhere in 2001 and said they were going to commit 15% of the national budget and more to health. But Ghana is doing somewhere around 9, 10. Other countries are doing even far lower than that. And when we are not investing so much in health, it does not allow us to do these kind of things. And that is where we need to go. And we need to improve the infrastructure, build new ones that will take cognizance of the fact that we need NICU units and build it well, so that those who have to work in that space can do their very best for our babies. And the psychosocial support that the parents and families needs to be improved. There should be more improved counseling centers beyond the schools that we have, the pre-pregnancy, the pregnancy schools and all of that. We need counseling centers that can, we listen to Paul, and all that he described were signs and symptoms of depression that the wife was going through. And we need centers that our health professionals can refer these. We do counsel, but it may not be enough, depending on the needs of that individual. You need specialists who will be in there, clinical psychologists and the rest, who can provide the necessary care to support these women during such trying times. It's never easy.
And we appreciate you for all you do. A round of applause for our nurses again. Thank you so much for all you do. Irene, we've heard Ohiniri say multifaceted approach. We've heard Perpetua talk about more training, investments, providing the very necessary amenities. But it gets to a point where everybody's talking multifaceted, but we are not seeing that approach. WaterAid is doing its best as well. But then again, who should lead it? Whose responsibility? I know you say governments can't do it all. That's become, like a cliche. But we do believe as well that we need a strong approach to face this head on. And she spoke about lack of trying to make some headway when it comes to investment in health. From where you sit, can we get it right, and how do we go about it?
Right, thank you very much. So, as a country, I think the first panel actually mentioned, they did justice to some of these things. We are doing so much. There are so many policies that is supporting the reduction of newborn death, but also improving quality of care. And when it comes to quality of care, and even for reduction in neonatal mortalities, it is everybody's business. However, when it comes to policy formulation and development, there should be a lead. And in Ghana and even in some other jurisdictions, the ministry takes that leadership role. However, the ministry cannot do it all. They need the implementation wings, the implementation agencies such as Ghana Health Service, but also development partners. And we have to say that all these partners, they just don't come to the table. They come to add value, giving oversight, giving policy-driven decision-making, evidence-based, because some partners actually work down there. They have projects that they implement. And based on that, they can bring in grassroots evidence to feed into the policy. And also, let me also say that it's important to bring on board the voices of communities. And that's important to say that CSOs are very key in this development process. So policy formulation is not just, and it's also not just a one-time approach. It's a process. It starts from somewhere and then it ends somewhere. It's also a cycle. At the end of the day, you identify a problem, somebody leads the development of the formulation, new issues arise, we need to update those policies based on evidence, not just ad hocly. And so that is what I'll add to the contributions.
Thank you so much. A round of applause for her. And I promised everybody that this will be very short. So we're doing our final round of questions. Perpetual, like I asked my very first panelist, if I gave you a blank check and I asked you, what really does quality healthcare mean to you? What would you want to see when it comes to quality healthcare? As a nurse, as a healthcare giver, what would it be?
Quality healthcare, for me, is the experience, the total experience of accessing health service, no matter what it is. No matter what the service I'm requiring, the total experience must be one that will give me fulfillment, will make me know that I got what I needed. So in that vein, we need to improve our health facilities. When you move away from the urban centers, you realize that there are some places that things are not going well at all. The Agenda 11 that the government is instituting, I'm praying that all those district health facilities should be put up well equipped so that no matter where you are, you can access quality health care. But the quality here is not also just about the building or the equipment that is in there. It's about the human-centered care from the health professionals, the compassion, the empathy, the service delivery based on evidence, an evidence approach in terms of what we do in terms of providing treatment or management for whatever conditions there are. And there should be a lot of motivation for the health staff so that they can continue to do what it is that they do. It's not just about my nurses and midwives, but of course for doctors, those in the allied profession and everybody, the motivation in terms of everything that has to do with conditions of service so that they can continuously do their best. The bit about the equipment, like I mentioned, is very important. We know our colleagues who are working elsewhere around the world, and we know the work environment in which they work. I was in Cape Town, South Africa. I felt I needed to just go check my breast, examine my breast. And the hospital that I went to, you enter and you can't even know that this is it's like you've entered a hotel. We are economically challenged, as a nation, but we can still get there. Once we set the goals for ourselves and leave partisan politics out of a lot of the things that we do, we should be able to approach health in such a way that we will be able to deliver health services to the population. National health insurance is not doing the best within its mandate or as an authority. I think the capping does not help. The capping of their resources does not help. The capping should be removed so that they will have enough money to be able to reimburse facilities when they give care or services to the Ghanaian population, no matter what the condition is. When they have enough resources at their disposal, all those conditions that are not on the list or all the medications that are not on the list now, they should be able to cover it so that no matter where I'm located in Ghana, if I enter any health facility, I should be able to access the health service without any financial burden on me. Thank you.
So much. A round of applause for her. Irene?
Thank you. So going back to what Madam just said, for me, quality care means a lot. And as an analyst, I will want to go back to evidence. There was a study, and I want to speak to data, but also to your heart. There was a study that was conducted. Women were asked in maternal health care facilities, at the NICU, within the labor, along the birthing process. They asked them, what really is your priority? What do you care for? Or what constitutes quality for you? And it will interest you to know that water, sanitation, and hygiene was the second. The first was respectful care. So respectful care, yes, but what do we see in our facilities? There's no water, there's no sinks. What is happening? We are even privileged to know that our regional hospitals have improved in terms of adequate water, sanitation, and hygiene. And I'm also happy to know that the first speakers actually endorsed or they reaffirmed that sepsis, infections are actually one of the leading causes of prematurity, even neonatal mortalities. So as much as possible, why are we not looking in that direction? Because a facility without wash is no facility. And personally, I had the opportunity to deliver my first baby, who was also a preterm, out of Ghana. I won't mention the country. But then it was interesting. I felt like it was a privilege. in Ghana, you may have to be the president's daughter to have that kind of service. I was like, whoa. So, and that was just a community facility. So just like you said, madam, it looked like a hotel. Yes, because standards are being put to practice. And so for me, quality of care has to be aligned with WASH, availability of water, sanitation, and hygiene. And let me also emphasize that it's not just the availability. Let's look at the correlation. What do we see when we improve facilities with adequate water, sanitation, and hygiene? Neonatal mortalities will reduce. And at a point, we need to just look at the very advanced life-saving devices instead of talking about these basic things, prevention. Why can't we advocate that every healthcare facilities do have adequate water, sanitation, and hygiene? Thank you.
So much. Round of applause for her and Ohenire.
You know, when I was listening to Mrs. Zoforian before, I just laughed and said, maybe she didn't go to Alexandria, which is behind Sandton City in South Africa. She would have seen real hospitals there. You know, we have such hospitals in Ghana here, where you enter and it's like a hotel. In fact, there's a dental clinic not too far from here. I'm not going to mention the name. You get in there and you wonder which part of the world you are. We have such facilities in Ghana, but how many people can access it? How many people can afford it? Even the average Ghanaian, not the rich, but the average Ghanaian. When you come to the Chief's Little Republic, there's a nice building there, and for years, it was I think 3 years ago, I organized an outreach program, where we went with doctors, pediatricians. That was when he got to know that when the people say they are going to see the doctor, they were going to see a midwife or a nurse, a senior nurse. There's never been a doctor at post there. There's never been even a PA, the physician assistant there. So for me, quality healthcare is getting the citizen to understand and own their health. Wherever they find themselves, even if that facility is in a kiosk, the help and the assistance and the treatment they get will be like what they will get in that 5-star hotel. There's a qualified nurse, there's a qualified doctor, there's a qualified midwife who will make good use of what they have. Because 1, they've been well-resourced. 2, they've been well-trained. 3, they went in there because they want to. Honestly, I am advocating that, in fact, we should institute a Professor Ifua Hesse Award, for healthcare in this country. For people,
and we support it 100%.
And she must be a course that must be studied.
Yes.
And I'm not saying this because there are few people, there are a lot more people like her. People who do what they do because sometimes when you go to these facilities, it doesn't matter where it is. It can be the first class, it can be the second, and you can go to the lowest, quote unquote health center, and you get the best treatment. My mother had diabetes, and she has special clothes that she wears to the hospital. And there's a particular doctor who was at Kolebu. Whenever she goes there, she'll come back and, meanwhile, the doctor only gives her water, mixed with glucose. Because of there's nothing wrong with her, but old age, so she's sick. She feels she's been seeing a doctor, so she has to. And that doctor was so patient. That's the diabetic clinic. I've forgotten, is at Kolebu then. But the way she was treated, and she shows symptoms of being sick at home. She'll come back healed, but they only gave her water with glucose. Bottom line, sometimes the way the health professionals interact with us. I was telling Selena, she didn't even know that my daughter nearly came too soon. It took a midwife, a young midwife. They were rushing me to the theater, and she said, no, let's monitor. She stayed with me for 24 hours. Monitored, did all that she could, and I was able to go through the 38. So sometimes the little things are the ones that matter, not necessarily the fact. I agree with the facility, the wash and everything, But sometimes the little, even a word that health professional can say to you will give you so much comfort. And because they said sickness is what? There's some percentages, some psychological, a percentage psychological, some whatever it is. And how come some cancer patients survive and some don't? How come some, it's all about sometimes the care. My mother, once again, diabetes, she was amputated at the hospital. They were in a room. There were 4 of them. Within 1 month, the other 3 died. She survived 4 years more. Why? Not because of just the care, but I, some years ago, had the opportunity to do the professional any work. Do you understand that one? The professional any work in somebody's country.
Yes.
And I was a health assistant. So I learned a few things that I could help her with. So it is a holistic approach. Health professionals, the individual, the family, the community, and the government. And for government, we'll say it over and over. I've been a journalist almost 30 years. What hasn't been said? What hasn't been promised? But, Dukaya.
Don't give up. Don't give up.
Oh,
believe.
Still we'll believe. One day, it will happen.
Amen. A round of applause for my panelists. And as you've heard them, I would want you to, as we close, go back home, do an inner reflection, and let's see what we can make out of the pointers they've shared with us, what actions can be taken, be it a health professional, be it a policymaker, a parent, an advocate. Remember that every voice counts, and together we can support maternal and child care here in our country, Ghana. I would want to say a very big thank you to my panelists, Mrs. Perpetual Ofori Ampofo, my dearest, President of the Ghana Registered Nurses and Midwives Association, Irene Owusu Poku, Health Policy Analyst, WaterAid UK. A round of applause for her. And then also Ohenire Gifty Auntie, a very special guest of honor and CEO of GDA Media. A round of applause for them. And I'll kindly ask that you take your seats. Thank you so much. Let's keep clapping for them as they take their seats. Do we have Selena here? She's at the back. Can someone kindly call her for me? I just saw her walk past. We'll be wrapping up very, very, very soon. How many of you have found this very educative, inspiring? How many of you have been touched? Please show by hand. Vote of thanks, and then we know what to do. How many of you? Please show by hand. Anyone here? And can I hand over the microphone to one person? Tell me what you've learned today. Just tell me what you're taking home. Anyone? Should I? Anyone? Oh. I saw some hands up, so please. I don't. The nurse, the pretty nurse. 2 of them smiling. I think I can have both of them answer my question.
I'm Araba Peninsula Eidu, and then I'm from Adabraka Polyclinic. So with everything that has been said today, my take home is, first of all, our attitude as healthcare givers. So psychologically, when we define health, psychology is part of health, emotionally, socially. So as parents, as family members, as health workers, we have to be able to liaise with family members together with the parents so that we can help them emotionally, because it goes a long way to help the mothers to care for the babies. Thank you.
Okay, I'm Christiana from Ganot Municipal Hospital. I think this is very educative, and as a midwife, I would encourage all of us here to be very supportive to mothers that have babies that are prematured, because usually when they come to us, the perception that these mothers have is they think if you have a prematured baby, it means that befobia, like it's a spiritual or a supernatural force at work. So we need to help them. We need to educate them more to know more about what actually causes it, and then what to do to prevent all this. Thank you.
So with our preterm babies, you know, our expectant mothers need our help. So we need to, it's a traumatic moment for them. So we need to encourage them, give them the support they need in care of their babies. And then no matter where we find ourselves, we should minimize disparities as we provide care to our mothers. Thank you. Please, I'm Maria Madauda, and I work at Guy's Municipal Hospital. Thank you.
Thank you. What really hits me was the fact that we tend to ignore the men, the fathers, and yet they can make a lot of impact. So I think we all should make a deliberate effort, healthcare workers, right from the beginning, pre-pregnancy, pregnancy, and throughout. Get them involved, get them informed. Because fortunately these days, the men are available more than before. And yet, if they come and they feel like they are redundant, I don't think they will be encouraged.
Thank you. Dr. Sego, please introduce yourself. Just for those who just joined us virtually.
Okay, Dr. Isabella Sego Moses. I'm a child health specialist, and I'm with ACM at the moment. I used to be with Ghana Health Service, now retired.
Thank you so much. A round of applause for all of them. It's now time to... Who wants to add, please? Okay.
Yes.
Please introduce yourself first.
Yes, I'm Nana. Yes, Dr. Nana Kaimbrakum, called Nana. Yes. Dr. Sego Moses is the one that made sure all these things happened. She just went on retirement. So from the 2006 that I mentioned, she was the director. So what we were experiencing by then had to be transformed. And before she left, here we are with a lot of improvement in our data. Neonatal mortality rate was around 32, 33, 34, around that time, per 1,000 live births. By 2017, she had helped, she brought together partners, a lot of policy documents came out, a lot of education and structures were put in place. And by 2018-17, neonatal mortality had dropped to 25 per 1,000 live births. And before she left, by 2022, our neonatal mortality had dropped to 17 per 1,000 live births. So all that I've been talking about, I was talking about her. Thank you.
Wow, we have a lot of trailblazers amongst us. And for the young ones, don't shy. When we close, network, don't run away. Go and ask the relevant questions. I hear, Prof, you have something to tell us?
Good evening, everyone.
Good evening.
First of all, I want to say thank you to the foundation, because what they did was a bit surprise to me. And I was sitting here shaking the whole time. But thank you so much for that honor. And the last panelists that are speaking, there's so many things that I have been a part of. What you said about appropriate technology, which is APROTEC, which we have done all our lives. But we're at the stage where we need to do more. The Abuja Declaration was 15% for health care. If you look at that 15%, 98% goes into paying salaries. So what is left to improve the rest of the institution? And that is therefore something that for us is woefully inadequate. And that's where other partners can come in. I give a talk on the difference between public and private sector in terms of healthcare, because I've had the privilege of working in both. And one of the things I talk about, wash. When I go to an institution, I can tell the culture of that institution by asking to go to a washroom. Sometimes you see people looking at each other and looking at which one, they'll say, oh, we'll go and open it and clean it before you come. But if each and every one paid attention to that, there will be something that your patients can be proud of. At least clean. At least toilet roll. Even sometimes for the staff, there's no toilet roll. But nobody seems to be bothered, or no one wants to be responsible. So it's something that we all should take on board. When our patients come with diseases, if we are not careful and we don't wash our hands, we will be taking it home to our own family. So I just wanted to add on some of these points. As for the brain drain, But what Ohineyere also said about what patients really are looking for in their doctor. At ACM, what do we call it? Heart power. It's in the middle of all our core values. Going the extra mile for your patients. Doing what others would not do, but that you are willing, and the patient knows. When you do that, when they pray, they mention your name. Yeah. And the blessings that will follow you cannot be counted. Thank you.
Thank you so much, Prof. We really appreciate that. It's now time for the vote of thanks, and I would want to call Selina Bintum. She is the founder of AFPNC to give us the vote of thanks.
We are closing. Thank you. We are grateful. This is our first edition, and we had an expectation, but I think from the feedback so far, our expectation has been exceeded, because Ohineyere had to stay a bit longer. Prof had another important meeting. We literally had to call, we were, the kind of planning we've done behind the scenes, you have no idea. And the beautiful part of her humility is that she couldn't even predict that it would be her. Prof, we are grateful to God and we are grateful to you. If you did not buy into this, when I gave her the call, she didn't spend 1 second to think about it. Selina, let's do it. And it wasn't like, let's do it, and so just do it and then I'll come. She made sure that the full administration, the staff, everybody was into. At some point, we felt like we are part of the ACM family. It's like somebody just said, your face looks up at me, and said, how? He said that, I've seen the ACM. And I said, but I'm ACM. Just that I'm not enrolled yet. And we have the president of GRNMA. I have seen her work and I've admired her from afar, but her humility, the way she would talk to me, at 8 p.m. we're talking, discussing it, waiting, Ohinia Gifty, auntie, you have no idea. Somebody was saying that, Mami on Chenuhu, I heard it. They were just talking about it, Mami on Chenuhu, and I have to say, Dr. Isabella Sego-Moses, one of the people who held my hand at the very early stages when I knocked on her door. I just came and I gave her, I sent the letter and they said I should speak to her. And beyond my work with her, she's become like a friend. Somebody that we can talk about non-work stuff, laugh, chat. She doesn't like talking, but I can make her talk. And after 1 hour, I said, Selina, I have to go. I know she's tired. And Dr. Brackon, we are so grateful. We called on him. He supported another project that we are coming up with. And he's still here. It is rare to have medical experts and high-profile personalities coming here, leaving everything just to support. And one of the reasons? Because of Professor Hesse. if some of the healthcare professionals here, when we say Professor Hesse, some of them now, I didn't have to mention my name. I said Prof, and that was it. And for all of you who believing in the vision and giving that respect to Prof, and also the believing in the AFPNC vision to come and support, it means a lot to us. We have some sheets here that we have given. Your feedback would mean a lot to us so that we can improve, and we'd love to stay in touch with you. So we are grateful to God for such a successful event, and also thankful to all of you. And yes, old but it's so real. AFPNC and ACM and Water Aid, I have to say, one of the amazing partnerships we've had also is Water Aid, and we look forward to what is yet to come with Water Aid for next year. They supported us financially to be able to take care of some of the expenses, and Impact Wave International, Pediatric Society of Ghana, Ghana Society of Gynecologists and Obstetricians, and the amazing Dr. Amma. We spoke yesterday for the first time, and she was just so much in support. Please, if I didn't mention your name, I haven't forgotten, but we are excited and we are grateful. Thank you very much. God bless you.
Selena, you've been saying a lot of thank yous, but we would also want to say a very big thank you to you and recognize you and say kudos to you for being the visionary behind this very important initiative. Your unwavering commitments and raising awareness and advocating for quality health care for babies born too soon is truly inspiring. Your leadership has not only brought together a distinguished group of experts, but it has also created a platform where we can all collaborate, share ideas, work together to make tangible difference in the lives of premature babies and their families. Thank you so much for your dedication, and we appreciate you so much.
Thank you, Wendy.
On that note, please don't forget to fill the form. Please don't forget to fill the form. And remember that every voice counts. We're counting on you to help implement some of the pointers we've shared here today. God bless you all. Thank you so much. I am Wendy Lai. You do have a lovely evening. So we have Ohiniyi's books out there. Don't forget to buy one. Please make sure you buy one.